see you. And for those who don't know, I'm Kristi Hart. I'm the home visiting administrator with the Division of Public Health. So my program is the Healthy Families America Maternal Infant Early Childhood Home Visiting Program. And I am presenting today with Virginia Jones, and I'll let her introduce herself as well.
Hi, I'm Virginia Jones. I also work at the Division of Public Health with Kristi. My home visiting program is called Comprehensive Family Support Services. So I oversee that. It is a statewide home visiting program, but we'll get into all of that. Kristi, do you want me to share the PowerPoint or do you want to share?
I can share. I've got it up. Hopefully it's as simple as hitting this present in Teams button. We'll find out. Click to present in your current. No. It says it's loading. Stand by. Maybe. That's not working. That. It's trying real hard. Are you seeing my slides?
I think it's getting there. It's a black screen for me, at least right now.
Nope.
No. Do you want me to try and share as well? I have it.
I'll try one more time.
Screen too. I don't know if your internet's.
Can't open file empty. Present one more time. Fingers crossed. And if not, then I will hand it over.
I got it.
Oh, okay. All right. Okay. Are you seeing what you should be?
Yes. Yep.
Okay, perfect. So we're here to talk about early childhood and family support home visiting. So a lot of what we are going to talk about is things, at least concepts that you may all be familiar with, but we wanted to go specifically into the work of with children and families. So the work that we're talking about today is voluntary family support home visiting. What that is regular planned home visits provided by either a health, social services, or child development professional. So it's a lot like what you do with a specific focus on parenting of young children and long-term goal achievement with families. So the work is a little bit more intensive. Home visits may include supporting preventive health and prenatal practices, assisting families with breastfeeding, bottle feeding, general nutrition of both family and baby or infant, toddler, child, as well as general nutrition and other care of babies. So things like diapering, child development, that sort of thing. Also goes over helping parents understand what typical child development milestones and behaviors might be, and providing anticipatory guidance around developmental milestones. So things like when you start feeding your baby solid foods and they throw most of what you give them on the floor, or most of it doesn't end up in their mouth, or gagging, all of those things that we know are to be expected, but as a first-time parent or a parent without having history of positive modeling may become really frustrating and could be a significant source of stress for families. We also go over promoting parents' use of praise and positive parenting techniques. So following, many families may not have experience with using positive parenting techniques, and there may be use of physical discipline that we really want to advise against, and talk about what the research demonstrates about effects of positive discipline. And then working with families to set goals for the future and problem solve. And I'm going to try this and see if it works. And if it doesn't work, we're just going to move on. Are you seeing my video right now or no?
No.
No. Okay. I don't think that's going to work. So I'm going to skip over that. Sorry about that. The last 5 minutes before I came on here, my computer started to do weird things. So my apologies. Here. So some of the programs that we have in New Hampshire, these are our early childhood home visiting programs. So when I say early childhood, generally the programs serve prenatal through about age 8. Some of them are lesser windows, and then Virginia's program serves for a greater window. But the ones that we have available in New Hampshire right now are my program, which is Healthy Families America, Comprehensive Family Support Services, Head Start and Early Head Start. The New Hampshire Birth to 3 program, also known as Early Intervention, formerly Family Centered Early Supports and Services, as well as several independent home visiting programs. Many of them are run out of family resource centers. So we have that you've been provided the slides, and here are a couple of links so you can identify where programs in your area are, as well as just other family support programs.
Kristi, your slides are not advancing on our side. We're still on the home.
Okay.
Sorry.
All right. I'm going to stop sharing and reshare for a second. I'm sorry. I don't know what is going on with this. Are you seeing them now?
So we can still see the first screen, or at least I can.
First one. Okay. So yeah, I'm gonna see Virginia, maybe do you want to share yours? Because mine is apparently acting up.
Yeah, I can share. 1 second.
Sorry about that, guys.
When you're sharing them, I'm able to filter through them myself.
Oh, interesting.
I wonder, Teams is getting a new update. At least we just got an email yesterday, and I thought, I'm not updating it till after this meeting.
I had the same thought.
So, we'll see. Okay, now I see
mistake.
Virginia's home screen.
Is it?
Okay, there we go. Yep, now it's
Okay.
on the second one, or third one.
Great.
Perfect. All right, thanks.
Okay, one more, please. Okay, so my program is the Healthy Families America program. So we're a statewide intensive evidence-based home visiting model. We utilize the Healthy Families America model, guided by an evidence-based curriculum, either parents as teachers or growing great kids. So what that means is each of our home visitors is trained by the Healthy Families America model. It's a national evidence-based model. There are more than 30 different states and tribes and territories that utilize this model. It's supported by a wealth of evidence. The Administration for Children and Families has a website that identifies the level of evidence for various evidence-based models, and this is considered a well-supported model based on at least 9 independent studies. So it's been demonstrated to be effective. So this program serves families with children prenatal through age 3. And then a change to our contracts in the last year expands the eligibility population for the families we serve up to age 5. The caveat to that is children enrolling up to age 5 are those referred by DCYF. So the primary enrollment population for your purposes would be families prenatal up to 3 months postpartum. Some programs do have the flexibility to enroll beyond that 3-month window, but it depends on what their caseload currently looks like. So because it's a very small portion of their population that can be enrolled beyond that time. And then services are able to continue for 3 years postpartum. So that's where the intensive evidence base comes in. So families that are appropriate for this program are ideally those who have a higher level of need than your average family. Families who have a history of trauma or active or past substance use, mental health challenges, a child or caregiver with developmental delays, families who maybe have unstable housing or who have a history of challenges with past involvement with child welfare system, families who need a lot of extra support and can benefit from ongoing one-on-one support every single week. So the eligibility for the program is determined by a tool that the model has developed called the FROG tool, which stands for Family Resilience and Opportunities for Growth. What that does is it's a personal history interview tool, and it supports the family resource specialist in working with the family to find out what their protective factors are, what their risk factors are, what their history looks like in potential areas that may be problematic in the future. So for example, if a person has a prior history of child protection involvement in their own childhood, they may not have great examples of what parental discipline means, or they may have a more challenging time with bonding and attachment. So by doing this personal history interview, it helps identify areas that could potentially be needs moving forward as well as current needs. And then the other piece of this tool is you work with the parent to identify what their personal goals are. So what do they hope to get out of this? Do they hope to be able to finish school or get a job or get their own housing or stable housing? Do they just want to be a better parent and don't know how? Do they have zero knowledge of child development? So it helps narrow down the trajectory of the service plan moving forward. Virginia, can you go to the next slide, please? So the goal of home visiting is really to focus on the family system. So years ago, maybe 20, 30 years ago, there were home visiting programs, but a lot of it focused on the professional working directly with the child. So the difference with this evidence-based model is it really focuses on supporting the parent or caregiver in doing the work with the child. So it's never going to be the home visitor working with the child to make gains. It's really going to be the home visitor supporting the parent or caregiver in interacting with their child so that they're the one accomplishing these things and they're the ones promoting their child's growth and development. The goal is to help improve caregiver-child interactions and show parents how to enjoy time with their child, which is a huge protective factor because opportunities for joy help families learn to be resilient over time. And then the other goal is building community and capacity, right? So we want to leave this family better than where we found them. We want to help them connect with their community resources, help them get connected with concrete supports, get health insurance, primary care. If they need benefits, help them get connected with things like SNAP or WIC or TANF. Really, whatever resources might be needed by a particular family, the goal is to help get them connected and show them how to do that so that way in the future they know how to do it. And then again, I talked about the providing anticipatory guidance around upcoming milestones. So talking about those things before they happen. Our home visitors conduct developmental screenings using validated tools. They conduct maternal depression screenings. They screen for family violence and substance use as well. And then the big piece here is that this is a voluntary service and it is free. So families are not being asked to provide their insurance information for the purpose of payment, only just to see if they have it and if they need help getting connected. And families cannot be compelled by a court or judge or DCYF to participate. So this is true. This program is required to be voluntary. So at any point in time, a family has the option of saying, I'm no longer interested, this no longer serves my need, or this wasn't what I thought it was going to be, or I just don't have time. All of those are okay. So a family is not required to participate in any way. Next. Actually, just one more thing about the free piece. So we primarily receive our funding. It's a federal grant fund, which is why this program is free. So our federal grant pays for families to participate in this program. So it is not coming out of anybody's pocket here. As far as families go or professionals, we do have a small amount of state funding as well. So the why behind the program, right? I'm sure as community health workers, many of you are at least familiar with adverse childhood experiences. But the goal of this program really is to mitigate adverse childhood experiences. What we know from the ACEs study from Kaiser Permanente was that people and families who have adverse childhood experiences, the greater number of ACEs they have, the greater chance of long-term health impacts, negative health impacts. Things like physical health, like cardiac issues, asthma, diabetes, mental health issues, substance abuse, cancers, broken bones, all fall under those. The more ACEs you have, the more likely you are to have these conditions that can adversely impact your health. So it's important. Next. So after that study, things were kind of feeling hopeless, right? Like you have this bad luck and your trajectory is just set for life. And what we know now is that's not the case. So I love this visual because it shows more the long-term effect. So we know that it's not just the bad things that happen to you, right? It's the climate that you live in, it's your home, it's your community. All of these things impact a person's health and well-being long-term. So we want to focus not only on what has happened to someone, but we want to focus on where they're living and what could be happening to them in these environments. So things like, living far away from a grocery store or a library, or not having transportation when you're living in a rural community. Things like having historical trauma or unemployment. Yes, having an unincarcerated parent, or having lack of food security, living in poverty, living through a pandemic, right? All of these things can negatively impact a person's health. So we need to make sure that we're addressing all of those things, not just traumatic experiences for families and individuals. Next. And this is where the HOPE framework comes in. So I really love this framework because it talks about what we can do about all of this. So it combines the insights of public health approach in preventing child maltreatment with broad understanding of how children grow to become strong, healthy, and resilient adults. The idea came about through conversations at the CDC, Knowledge to Action Task Force on Child Abuse Prevention. The CDC approach emphasizes the public's need to support safe, stable, nurturing relationships and environments for children. And that's where home visiting comes in. So the focus is really on supporting childhood experiences in 4 categories. So being and nurturing supportive relationships. So whether that is with a caregiver or someone in their community, ideally multiple people, not just one, but at least one. Living, developing, playing, and learning in safe, stable, protective, and equitable environments. So for home visiting, what that means is getting people acclimated to their community, letting them know what's available for resources in their community, letting them know where the safe places are. If they're, if you're living in a city, where are your green spaces? Where are your libraries? Where are your community family resource centers? Having opportunities for constructive social engagement and connectedness. So that might be a parenting group, that might be a walking group. It might be getting connected with, your local library programs once a week. It might be a dance class in the community. And then learning social and emotional competence, right? And that's done through relationships. Next. And then I like this visual because it just kind of shows it in a little simpler, easier to understand way. And I'm sure many of these things are the things that you all do with individuals as well. But I think it's important just to highlight for those, if you're working with a family that has young children, these are some really simple kind of visual blocks that you can utilize to help families understand the importance in these broad areas. Next. So I talked about that this is an evidence-based model, and here's some of the evidence about the Healthy Families America model. I'm not going to go read through all of these, but the biggest things that we like to promote for the program that have been identified as positive outcomes from the program are an increase in positive parenting practices. So parents were more confident and they reported using more positive discipline strategies as opposed to physical discipline and doing less yelling. There was improved child health. So the rate of low birth weight babies born to HFA families was 48% lower among enrollees in the program. And it also increased the number of mothers who chose to breastfeed. So breastfeeding, we know, is really healthy for both moms and babies for a number of reasons. And the program increases breastfeeding. The program also demonstrated fewer visits to the emergency room compared to their non-HFA counterparts. Let's see. A reduction in child maltreatment, which is huge. So I mentioned at the onset that we have a partnership with DCYF. So we're now in a joint contract with Child Protective Services to help enroll child protective families into the program to reduce recidivism and reduce child maltreatment in the future. So based on self-report, families were less likely to return to child welfare services or systems following completion of the program. And families enrolled prenatally and experienced the greatest benefits. And then improved family economic self-sufficiency. So what are those things that we know that gets family out of poverty, right? Having housing, having a job, having money. So helping families connect to those resources and getting them connected to that schooling or that educational training can help improve their circumstances and economic self-sufficiency over time. So they're not always going to be reliant on benefits. So that can really be a blip in time. And then, so this was 19 randomized control studies. I think I said 9. It's actually 19 randomized control studies. And you can find the information on the research on the Healthy Families America website. Next. And here are some additional outcomes. So increases in linkages and referrals. So HFA connected families were more likely to get connected to essential community services, things like family planning, connection to TANF as well as SNAP benefits. There are improvements in child development and school readiness. So children enrolled in the program were less likely to be held back a grade and were more likely to be in advanced programs by the time they were in first grade. Improved maternal health. So HFA reduces pregnancy complications by 70%, bolstering mothers' mental health, lowering parenting stress, helping moms avoid risky behaviors, including reducing alcohol use, marijuana use, and increasing the use of condoms, which also we know family planning is huge, right? When you're talking about improving health, you really want to space out your pregnancies further and help families identify what their family planning goals are before they end up having a subsequent birth. And then what we know from our New Hampshire specific data, an evaluation of the program done in 2017 and 2018 found that families enrolled in the HFA New Hampshire program were more likely to access preventive services at a lower cost than their non-HFA Medicaid counterparts. Medicaid recipients who were not HFA served by the HFA program were more likely to access emergency services at a higher cost. So when you're talking about cost benefit analysis, it's really important to be connecting families with these preventive services like healthcare, health insurance, primary care. Next. And just a quick rundown, these are the priority populations. As I mentioned, we are federally grant funded. So these are the populations mandated by our grant that we need to be enrolling. So families with a low income, so I believe it's below 110 or 150% of the federal poverty line. Household containing an enrollee that is pregnant or under the age of 21. Household with a history of child abuse or neglect or has a history of interaction with the child welfare system. Households with a history of substance abuse or someone who needs substance abuse treatment. So this could be the primary caregiver or secondary caregiver or a partner. Someone in the household is a tobacco user. This one always, I think, surprises people, but as you probably know, the use of tobacco is also an indicator for a lot of other higher risk health issues. So tobacco use is a consideration for the program as well. Someone in the household who has attained low student achievement or has a child who has attained low student achievement. A household with a child with a developmental delay or disability, and then households including individuals who are serving or formerly served in the U.S. Armed Forces. So those are our priority populations that we're serving. Like if they meet one of these categories, they qualify. Next. And then educational requirements. So I always like to do a little plug for the program. If you are working with a family who is looking for employment, or you know other people who are seeking to do this work with families who are prenatal or with young families, the program is really flexible with regard to the professionals that we hire. So you do not necessarily need a particular educational level beyond a high school diploma or equivalency. So in HFA, it's all about the qualities that an individual has, not just their education. The program emphasizes the need for home visitors to be able to build relationships and trust with families. So that's what we're primarily looking for. We have a number of different agencies that implement the program that may have their own educational requirements, but the model overall does not have that requirement. And many of our agencies are moving more toward a lower educational requirement in favor of identifying individuals who can demonstrate the ability to build trust and relationships. The exception to that is our program offers a registered nurse model enhancement. So the HFA model does not offer nurse home visits, but in New Hampshire, we have opted to add registered nurse visits to our array of services. What that means is each family who receives HFA services is also offered home visits by a registered nurse. So that happens once per trimester prenatally and at least once per quarter in the first year of life. For families who have higher risk medical needs, either by a caregiver or child, they may be seen more frequently by the nurse, and the nurse is also available for consult as needed. With this, the nurse is a nurse educator. She does not provide clinical services. There are circumstances where our nurses, because of the organization that they work with and the skill set that they have, that they may do things like take vitals or weigh the baby or offer lactation support, but they are not billing for clinical services. Next. And then this is the location of our programs. So we currently have 6 local implementing agencies that serve the entirety of New Hampshire. So the northern part of the state is served by the Family Resource Center at Gorham. Granite VNA serves the Laconia and Conway regions. TLC Family Resource Center serves the Claremont region. Community Action Partnership of Stratford County is Stratford County area. Waypoint serves the southern and seacoast areas, as well as Manchester and Concord. And then home health care, hospice, and community services serves the Keene area. So there are programs that cover the entire state, regardless of where a family is located. Next.
Okay. Sorry, my computer
That's
had a glitch.
Yeah, mine did too. I'll pass it over to Virginia now.
Awesome. So thank you, Kristi, for kind of going into a lot of the details around home visiting and the benefits. Comprehensive family support is slightly different, but all the main goals are there around building protective factors and addressing ACEs. So comprehensive family support, home visiting, CFSS, it's quite a long name, so I apologize. It's also community-based, voluntary, and free. It is in 11 family resource centers across New Hampshire. So this is our map, which is probably very hard to see, but if you ever have questions around any of the locations, you're welcome to reach out to us directly. So this provides preventative services for pregnant parents and families with children ages 0 to 21 years old. And the services are based on individual needs. And this map follows the DCYF district office catchment area. So there's a program available in each of those catchment areas. So there we go. So comprehensive family support services home visitors utilize evidence-based curriculums, much like Healthy Families America. So there's two main curriculums they use called Parents as Teachers and Growing Great Kids. And staff are provided additional training in the Strengthening Families frameworks, positive solutions for families, the protective factors framework, motivational interviewing, and also professional development as needed, as identified for the staff and based on the needs of the families that they see. So CFSS is quite broad in terms of the things that they might do with a family or the goals that might be set. So some of the primary services include the case management piece through the home visits, household management, positive parenting and support, parent education, budgeting, developmental screenings, connections to resources like Medicaid, SNAP, and a piece that is unique for CFSS is preventative child care. So that is a child care subsidy that is available to those participating comprehensive family support services. There are some eligibility requirements for that program that are specific to employment and age of the children. But that is also to help families overcome barriers and to work on goals while the child is in care. So CFSS with the family resource centers, the program's embedded in them. So they work together in conjunction to provide the family with the support that they're looking for at the community level to address, social determinants of health and focus on primary prevention. So each family, I kind of mentioned, they set goals. They work with their home visitor to create an individual support plan that's specific to them and their needs. So depending on what their needs look like, it could be a short term, 1 to 2 months with their home visitor, or it can go up to 12 months. There are some programs that have had specific cases that have gone on longer, which is totally appropriate. And then whenever a family discharges, they can always access the program again. So it's not something that you can only enroll in once. So since the program does work with the family resource centers, there are some benefits to that, that the family can access more services outside of that home visiting piece. Resource and referral navigation is a big one. Again, parent education. A lot of the FRCs have play groups and support groups for families, kinship caregiver support. So those that are relative, fictive or non-fictive kin caregivers can receive support through Family Resource Center, concrete supports, and then also the social connections that come from those groups. So I did pull a little bit of data and I did not clarify this. So CFSS is a New Hampshire specific program. So we don't have some of the same requirements that HFA does. It is a braided funding source. There are some federal funds in there, but they don't have as specific of requirements as HFA might. So it kind of, what we track and monitor is kind of what we see over time as needs. And we're coming up to a contract renewal where some of this might change a little bit, but generally we're looking at like parent outcomes, like life skills, parent education, medical health and education, family mentoring and advocacy is also a big one. So this is just some data from the last state fiscal year of who all participated in the program and some of the outcomes that we measured. So our largest referral source is DCYF, so there's those partnerships there as well, to get families to that community level instead of engaging with DCYF, if that is the appropriate way to go. In state fiscal year 2023, so that was July 1st through June 30th, 1,158 families were engaged in the program. And that breaks down to well over 1,000 adults and children. And then we discharged 646 families. And this data also just reflects families who had that individual support plan created. So if a family engaged and did enrollment and then decided not to complete the program or disengaged, then we didn't count that in that data because it was kind of a very light touch with them. So we didn't get to monitor some of these goals. So I listed some of the outcomes below. It's in the 70-80 percentile that families achieve some kind of progress in these areas. And that could be they achieved their goal partially, or they mostly achieved it, or they reached all of their goals. We kind of look at the broader view in that way so that we can see what families are working towards as opposed to who completed 100% of all of their goals. Another outcome that we monitor is DCYF outcomes, so much like HFA, trying to engage families to prevent further engagement with DCYF. So I have 2 slides on this data. I won't go into all the little details, and I apologize if the images are small. But this is, we call it the class of data. So each fiscal year, we look at the children who graduated or discharged from CFSS, and we monitor them for 3 years after their discharge to see if they've engaged with DCYF services. So for the children who participated in discharge last year, so far 98.9% of them have not had a founded case of abuse or neglect, and 91.3% so far have not had an accepted investigation with DCYF. So a call may have been made, but it was reviewed and it did not have an investigation open. There's a small portion, that green piece in that second circle, of kiddos who had an investigation, but it wasn't a founded event of abuse or neglect. And then an even smaller portion that there was a founded event, or the yellow shows those investigations that are in progress. So there has not been an outcome determined yet. And since we follow this for 3 years, the most recent full set of data I have is from the kiddos in 2020. So I wanted to share some of that just to show you the long-term impact of participating in these preventative programs. So kiddos in 2020 that discharged, of those 96.3% over the 3 years did not have a founded case of abuse and neglect. We also look at, I kind of explained that already. We also looked at the calls to DCYF if there was an investigation open. So 69.9% of those kiddos over 3 years didn't have that accepted investigation happen. There's right around 30% had an investigation with no, and then 26% of that, it resulted in no finding of maltreatment. So this data kind of shows us a correlation between accessing community-based preventative services and reduction in services or engagement with DCYF later on, which is huge. It reduces the cost of for DCYF services, and we can see that families are engaging more with community-based providers. They know those resources are available. They're more likely to return back if an issue is emerging rather than getting to that crisis level. So that's super positive outcomes. And that's pretty much all for CFSS. Our information is in here. If you have any questions or are like, I have a family who's here and don't know kind of where to send them if they're looking for home visiting, you're welcome to reach out to either of us individually for each program. We sit right next to each other pretty much, and we communicate all the time. So we're happy to help you navigate and identify the correct program, because we don't want the families to have to worry about what's HFA and what's comprehensive family support. It's like, we just want them to know that home visiting is available. And what was I going to say with that? I think that's pretty much it. So if there's any questions, again, you can reach out to us at any point, and we're happy to answer those questions for you. I don't know if there's any questions that you all thought of during this time, but